Okay, well, it's a real honor to present Dr. Harry Adams. I've known Dr. Adams since 1989. He hired me back then, and I was a lot younger at that time, and so was Dr. Adams. I'll give you a brief. Dr. Adams said make it brief, so I guess he's got a long lecture to give. So Dr. Adams is from Texas. He spent some time in India, which he's told me a lot about, when he was in high school, I guess, and graduated from high school in India. He went to Baylor University and graduated from there, then went to Baylor College of Medicine and graduated from there. And from there, let's see if I get this right, Vanderbilt, and then the University of Washington in Seattle. And he's been, did I get that right?
Yeah.
Okay. He's been at the Brody School of Medicine, then East Carolina University, since 1984. So this is his 30th year. And I think there are not too many people in this room. In fact, I suspect there's not anybody in this room who's been here as long as Dr. Adams. That was meant to be a compliment. Okay. Over the years, Dr. Adams has come to be known as an excellent teacher, and he's got several teaching awards to support that. I think probably the highest award he received is the Master Teacher Award, which he received in 2010. And I think the students really love Dr. Adams, and he gave their graduation speech, I think, a couple of years ago, and I attended that. He's respected by the students, he's respected by the residents, he's respected by our fellows, and he's certainly respected by our faculty and me. As I said, I've known him for many years. I consider him a good friend, and he's really the consummate physician. We don't have many physicians like Dr. Adams anymore. I think if I got sick, I'd want him to be taking care of me. Now, if I got run over by a car, I'd probably want somebody else. But at any rate, we're looking forward to his talk today, and this will be basically his final grand rounds in the Department of Medicine. Before he starts, though, Dr. Siraj talked to me recently, and we got together and got a plaque for Dr. Adams. And it's not long, and then I'll sit down, okay. And here it is, and we're going to present this to him now. From the Brody School of Medicine, presented to Harry G. Adams, MD, in recognition of 30 years of service and teaching excellence in the Division of Infectious Diseases, from the Division of Infectious Diseases, Brody School of Medicine, Greenville, North Carolina. So, Dr. Adams.
Thank you all very much. What I would like to do this morning is, if I can remember my threefold task, one is present three interesting patients. I think the ID division has seen all these patients, or have heard of all these patients before. The second is to make some general teaching points about these particular patients. And the third is to kind of showcase the kind of patients we see at Brody School of Medicine and Valiant Medical Center. I've been in a number of different places, and the best patient material, teaching material, is right here in Greenville, North Carolina. I want to thank two of our fellows, because I liberally lifted material from their presentations that have been presented before. Dr. Ari Frankel, who's just arrived. Okay. And Dr. Ramsey Ramawi, who is now a critical care fellow, but was a fellow in our program last year. So I'm going to start off. The first case is actually two cases with the same diagnosis. First is a 60-year-old male with hyperlipidemia who developed a sudden onset of severe headaches, nausea, vomiting, watery diarrhea, and abdominal pain. He went to his local ED, given us oseltamivir, that drug which we've learned now probably doesn't work, Tamiflu, for presumed influenza. He did not improve and returned, and when he returned, he was admitted with a diagnosis of pneumonia. Chest X-ray and CT showed bilateral lower lobe infiltrates. Along the way, he was transferred to Vidant. Blood cultures were obtained, and he was started on piperacillin, tazobactam, and vancomycin, Zosyn and vancomycin. His respiratory status deteriorated, and he required intubation and mechanical ventilation. Tracheal aspirate was obtained, was unremarkable. After 3 days, he was extubated, and he improved to the point where he could be discharged, I think about 2 days after extubation, on a course of to complete a 10-day course of doxycycline. Here's his chest X-ray. You can see he's got bilateral filtrates, but more prominent, if I can get this, more prominent on the right. I know this pointer works, but I'll figure it out in a minute. Second case. This man was in the hospital at the same time at Vidant. A 61-year-old male who developed night sweats, chills, and fever. He too went to the ED where a chest X-ray showed bilateral infiltrates, so he was started on ceftriaxone and azithromycin for community-acquired pneumonia, and along the way was also transferred to Vidant. He too had respiratory deterioration and needed intubation and mechanical ventilation. Chest CT demonstrated a right lower lobe loculated effusion, right lower lobe infiltrate, and a pleural-based left-sided infiltrate. He underwent video-assisted thoracoscopic surgery with decardication, and he clinically improved. Sputum and pleural fluid cultures were unremarkable, and blood cultures were negative. All these were at Vidant. Since he had a history of heavy alcohol intake, it was felt he had an anaerobic empyema with aspiration and developed pneumonia and empyema, and so he was discharged on IV ertapenem for follow-up in the ID clinic. Here's his chest X-ray. You can see a lot of right lower lobe stuff. There was also an effusion there, turned out to be an empyema, and a pleural-based left-sided mid-lung infiltrate. Here's his CT scan, again showing the same picture, but a lot of fluid on the right. Further information. The ID consult service saw both patients. I think I was one of the attending, and we had another attending who saw, one attending didn't see both patients while they're in Vidant, and they knew they were buddies who hunted rabbits, but they claimed they did not skin the rabbits. After both patients had been discharged, a positive blood culture from case number 2 obtained at the outside hospital, before he was transferred here, was identified by the state lab as Francisella tularensis. Shortly after that time, both patients were seen in the ID clinic, and at that time they both admitted to regularly skinning rabbits, which they had denied earlier. And they've been doing that, hunting rabbits and skinning rabbits and eating rabbits for years, for decades. They were both started on 14-day courses of oral ciprofloxacin. They returned a couple of weeks later, and they were both doing extremely well. So here we've got 2 cases of pulmonary tularemia. That's what I wanted to focus on. Here are some of their lab results. The first patient actually did have a tularemia titer when he was in the hospital, which is below kind of what we consider diagnostic level of 1 to 160, but his convalescent titer had more than a 4-fold rise and was 1 to 512. The other patient, before they knew about the positive blood culture for Francisella tularensis, he had a tularemia antibody titer, which is very high, IgM and IgG. And then I think the next day, after this was drawn, the lab called and said his blood culture was positive for Francisella tularensis. So I want to talk a little bit about tularemia. It's caused by Francisella tularensis, which is a fastidious, small, gram-negative intracellular coccobacillus. It is a zoonotic disease that can be acquired a number of different ways. Bites from arthropods, handling of animal carcasses, consumption of contaminated food or water, or inhalation of infected particles. The arthropod is most commonly a tick, but it can be deer flies, and actually in Europe, mosquitoes can also be a vector for transmitting tularemia. It can be aerosolized through lawn mowing and brush cutting, thus increasing the risk to landscapers and farmers. And tularemia, as I'll show you in a minute, is endemic in Massachusetts and Martha's Vineyard. And there have been a number of cases acquired that very way. And it is an agent of bioterrorism. So every time a case is diagnosed, it's reported, and folks think, could this be a situation where there's bioterrorism? It was pretty frequent in the U.S. before World War II, but the number of cases have declined since then, and there are about 100 to 200 cases per year now. The greatest number of cases are reported in adults, but the highest incidence is in children, ages 5 to 9, and older adults. I'm not quite there yet, but I'm getting there, 75 to 79 years of age. And about 70% of the cases occur in males, and it occurs most commonly when folks are exposed to ticks or maybe they're out hunting between the months of May and September. Here is, I think, from 2002 to 2013, distribution of tularemia across the U.S. Aha! Different kind. And you see most of the cases are centered around the south central U.S., some in the Pacific Northwest, and here are all these cases in Massachusetts, particularly in Martha's Vineyard. In North Carolina, there have been, counting our 2 cases, 17 cases since 1999. So it's really a rare disease in North Carolina. 5 were ulceroglandular, associated with tick bites. 3 cases were exposure to wild rabbits. 2 cases due to cat bites. Cats and dogs can possibly transmit it. 2 cases were unknown, but the patients were hunters. 2 cases with glandular and pulmonary disease. And 1 case, an immunocompromised patient who had tularemia meningitis and died from that. We had a case, was that about 3 years ago, 4 years ago, Paul? Here, who had tularemia meningitis, and it was a post-mortem diagnosis, and ID did not see the patient, but we talked about him after his death, but he had tularemia meningitis, probably from either ulceroglandular or glandular tularemia. And here are the culprits. It's got a nice catch of rabbits there. And our patients did claim to eat rabbit salad. Thank you for these slides, Dr. Frankel. And here you see fillets of rabbit on green salad. And we hope that the rabbit fillet were well cooked. And here are a couple of reports about our patients, one from the Wilson Times, one from the Charlotte paper. I think I may have been in Nicaragua when one of these cases was reported, and I was surprised to have opened up USA Today where they have the state-by-state information, and they had a little blurb about 2 cases of tularemia in rabbit hunters, which was our 2 cases. So the presentation, ulceroglandular is the most common. Typhoidal is hard to know. Some say it's up to 30%, some say it's 5 to 10%. This basically is the acute illness without any localizing symptoms. Glandular is just a lymph node involvement without the ulcer. Oropharyngeal is from ingestion. And it may be that our patients acquired their tularemia from ingestion of of rabbits. Oculoglandular is infection of the conjunctiva. And pneumonic, of course our patients had that, can be from either ulceroglandular or typhoidal. And a recent review said it felt it was more common in the typhoidal version, where the patient has systemic illness but no localizing route of infection. Here's an ulcer on the leg in a patient with tularemia. Probably this is from an arthropod bite. I think if someone's working with rabbits or other potentially infected animals, their route of entry is probably the upper extremities. Pneumonic tularemia. In the U.S., pulmonary involvement is reported to occur in 25 to 64% of some recent, fairly large series recently reported. And the radiographic features are quite variable. Sometimes you can have patchy infiltrates, you may have a unilobar pneumonia, or you can have multilobar pneumonia. And pleural effusion can occur in 20-30%. Remember, one of ours had a big pleural effusion, and you may see hilar adenopathy, and our patients do not appear to have that. So the clinical presentation is very similar to a community-acquired pneumonia, The patients may have higher fever, they may likely have headaches, but it's hard to differentiate this from atypical community-acquired pneumonia. So it's very important to ask about the risk factors. And they were asked in these two patients, but didn't lead to the correct diagnosis until the blood cultures came back. This organism is difficult to grow in the lab, and it's a laboratory hazard. So if you have a case of tularemia, you think you've got a case of tularemia, and you send specimens to the lab, let them know you're thinking about tularemia so you don't expose the folks in the laboratory to this organism. The usual method of diagnosis is serologic, and you're looking for either a fourfold rise in titer, which is the best way to look for it, or usually a tube agglutination titer of 1 to 160 or greater, and that's the test that was performed on our two patients. The drugs of choice are aminoglycosides. Streptomycin has been, but now gentamicin is probably the drug of choice. It's given IM or IV. Treatment's usually about 7 to 10 days. An alternate drug would be tetracycline, but there is a higher relapse rate after tetracycline. And remember, both of these patients got put on ciprofloxacin, which is probably one of the later drugs we've learned which is effective against tularemia. Probably a lower relapse rate than tetracycline, but limited data available. So, don't do this. I was guilty of anchoring bias. Anchoring bias is where you think you have the diagnosis and you exclude other possibilities. I didn't keep an open mind. We knew about the possible rabbit hunting, but I said, oh, this patient's alcoholic, he's aspirating, he's got an anaerobic pneumonia or anaerobic empyema. So I didn't give enough weight to the history of rabbit exposure, and so I don't know if I would have made that diagnosis if I given more weight, but I didn't strongly consider it. And I do think that even though tularemia pneumonia is quite rare in North Carolina, it should have been more strongly considered in the patient I saw. Okay, that's case number 1. Case number 2 is when a sore throat is more than just a sore throat. And I think this patient was on the medicine service, and I know some of you over in MIU and some of you saw this particular patient. 24-year-old female, previously healthy, presented to an urgent care center with a sore throat along with some fever and chills. A rapid strep and a rapid influenza test were negative, and so she was not placed on any antibiotics or any anti-influenza therapy and was just treated symptomatically. Over the next 10 days, her symptoms worsened with worsening throat pain and pain on swallowing, pain on the left side of her neck, and more fevers and chills. She was admitted to an outside hospital and transferred to Vidant. So in addition to the previously mentioned symptoms, she also had increased dyspnea and left-sided chest pain. And on exam here, she had fever, increased respiratory rate, and some swelling and tenderness on the left side of her neck, kind of up in the angle and just anterior to the left sternocleidomastoid muscle. On pulmonary exam, she had some decreased pulmonary sounds at the bases bilaterally. And her lab studies were remarkable mainly for a leukocytosis, and here are her chest x-ray and CTs. Chest x-ray, hard to say. She's got a lot of stuff on the left. Looks like fluid and something else going on, and maybe some stuff on the right. Kind of hard to say exactly what's going on there. And then we see her chest CT. And kind of in the mid-lung, she's got these cavitating nodules. Some areas over here, probably here. On the left, she's got some cavitating nodules and a pleural-based infiltrate stuff there. And then we get down to the bases, you see she's got a pretty sizable effusion. So this is a picture of septic pulmonary emboli. Here's a CT of her neck with contrast. You see contrast in the right internal jugular vein, and you see the left internal jugular vein is thrombosed. There's a lot of swelling, inflammation around that, and inflammation in this area. So this is a thrombosed internal jugular vein. Just prior to her transfer to Vidant, a blood culture was found to be positive for a gram-negative rod. grew in the anaerobic model and was finally identified, or pretty quickly identified, as Fusobacterium necrophorum, an anaerobe. She was initially treated with IV ampicillin sulbactam and switched to oral metronidazole prior to discharge to complete a 4-week course. Because of increasing left pleural effusion and desaturation on sitting up, she had 2 therapeutic thoracenteses. Remember, she had that fluid on the left, and finally required a chest tube, which was removed before her discharge. Because of what was interpreted on serial neck CTs as progression of jugular venous thrombosis at the outside hospital, she was placed on IV heparin, and anticoagulation was discontinued before she was discharged. When ID reviewed the serial neck CTs with radiology, the radiologist felt there had not been progression of the thrombotic process. It had been stable. It had not progressed. On follow-up 2 weeks after discharge in the ID clinic, the patient was doing very well. So this patient meets all the criteria for Lemierre syndrome or jugular venous suppurative thrombophlebitis. This infection originates in the pharynx. From there it spreads via the tonsillar veins to the internal jugular vein, where it causes a suppurative thrombophlebitis. And then there's bacteremia and dislodging of infected clots, which go primarily to the lung, but they can also go to joints, the heart, the meninges, and so forth. The hallmark features of Lemierre syndrome are primary infection in the oral pharynx, bacteremia, documented by at least 1 positive blood culture, which she had, radiographic or clinical evidence of internal jugular thrombosis, which she had, and 1 or more metastatic foci, and she had that. Usually the metastatic foci are to the lungs. So she had septic pulmonary emboli. Here's what you might see. Here is a dilated thrombosed internal jugular vein. Lemierre's primarily affects children, adolescents, and young adults. And these are folks that we've seen a number of cases here, and they are previously healthy. So this kind of really sneaks up on you because these are healthy folks. The interval between the sore throat and the onset of the thrombophlebitis is usually less than a week. I think her case was about that time, maybe a week to 10 days. And here is a diagram from up to date. Shows you, this is the parapharyngeal or lateral pharyngeal space. And anteriorly it's empty. Posteriorly it has a carotid sheath, in which is the internal carotid artery, the internal jugular vein, and cranial nerves 9, 10, and 12. And you can see this is adjacent to the rectopharyngeal space, the posterior pharynx. Here are the tonsils. And so this goes to the tonsillar vein up in, and they communicate with the internal jugular, and from there it spreads to the internal jugular vein. Here's another diagram. Originates in the pharynx, goes from the tonsillar veins to the internal jugular, and from there, this particular Fusobacterium necrophorum has platelet aggregating properties. So there's a tendency to form clots, and of course the clots get infected, they break off, and they cause metastatic infection. And primarily what you see are bilateral septic pulmonary emboli. Most commonly, the pathogen is Fusobacterium necrophorum. Other pathogens, as listed up here, can occur. Most of these are anaerobes, but Eikenella, streptococci can produce this picture. If your patient has an internal jugular catheter, the spectrum changes. Then you've got to worry about skin flora, like coagulative staph and so forth, and Staph aureus. So that clinical picture, you have a very similar clinical picture, but a different spectrum of microorganisms. Clinically, our patient had very classic clinical presentation: high fever with rigors, respiratory distress with pleuritic chest pain, localized neck and throat pain, and tenderness over the jugular vein or along the sternocleidomastoid muscle, septic emboli to the lungs. Patients can also have other septic emboli, and the second most common is actually septic arthritis. And several years ago, we had such a case in pediatrics, a patient that had septic arthritis from a Lemierre syndrome. Evaluation: blood cultures are frequently positive. CT of the neck should demonstrate this jugular vein thrombosis, which we saw, and surrounding soft tissue swelling. And of course, the chest CT and the chest X-ray should demonstrate, in most cases, almost all cases, septic pulmonary emboli. Therapy is primarily with antibiotics, and I think empirically using a beta-lactam, beta-lactamase inhibitor like we did in this case, ampicillin, sulbactam, which is unison, or possibly a carbapenem like ertapenem. And then when you have the organism, or if you get the organism, then design your therapy to direct it against that particular organism. So when we recovered Fusobacterium necrophorum from her blood cultures, we switched her to metronidazole. Surgery used to be the treatment before antibiotics because there was no other therapy. Now surgery is rarely needed, but if you have a continued emboli, you have a progression of this thrombosis, and they're not responding to medical therapy, you may need to ligate and excise the internal jugular vein. Since I've been here, I've seen a number of these cases. I've never seen that required. Anticoagulation is controversial. Remember, she got IV heparin. If the patient on medical therapy shows progression of the thrombus, progression of the process, I think then that's where you consider anticoagulation. So when to suspect Lemierre's, suspect a diagnosis if the following occur. You've got pharyngitis that's not resolving in 3 to 5 days. The patient remains sick or getting sicker. They have systemic or respiratory symptoms. Pharyngitis with lateral cervical pain and dysphagia, or pharyngitis followed by sepsis and or multiple pulmonary abscesses. So teaching points, Lemierre's may be considered a rare disease, but I think we've seen 8 to 10 cases, right, Dr. Cook, in the past 5 to 6 years. We see a couple of cases a year, and you've got to recognize it. If you don't recognize it, you delay therapy, these patients can die. So don't be misled by the pulmonary manifestations and call this pneumonia. Don't overlook the history of pharyngitis with a neck pain. That's a very important clue. And don't attribute the chest X-ray or CT findings when they have septic pulmonary emboli to a tricuspid valve endocarditis. By the way, our patient, I think she did have an echo, which was negative, but you may think with septic pulmonary emboli, you've got a tricuspid valve endocarditis with bilateral emboli. Don't fall in that pit because this can cause the identical clinical picture Lemierre's disease can. Now, know the natural history and responsive therapy to the disease you're treating. In the literature, it says these patients take 8 to 12 days to defervesce. Our patient took less time. But if she had remained febrile for a week and was looking better otherwise, stay the course. Don't rush in and change your antibiotics and so forth. Because the natural history is on therapy, they're going to continue to be febrile for 8 to 12 days. Now, one more point is to review the critical tests and labs yourself. I know Dr. Dillon, I believe, was on this case, and he contacted the outside microlab and to learn the identity of the organism. We had the results faxed to us. We did not use word of mouth before we directed the specific therapy. We also reviewed the chest X-ray and the CT scan with radiology. That's always important. And we found that this next CT, the two studies about 5 days apart from the outside hospital, did not show progression of the thrombosis. So we would not have anticoagulated the patient. Okay? Third case. We're doing pretty well on time here. Sepsis in a snake handler. This is an exciting case. I think we have the right diagnosis. This is a 29-year-old woman, while feeding her pet snake, was bitten on the right index finger by the snake's dinner, a rat. She washed the wound, but 2 days later developed chills, fever, nausea, vomiting, diarrhea, and had worsening of the process at the bite site with very raised, extremely tender erythematous. She also had myalgias, arthralgias, sore throat, cough, and pleuritic chest pain. She was admitted to a local hospital where she was actually looked like she was in septic shock. She got fluids and had to be put on pressors. She was started on antibiotic therapy. I don't endorse this regimen, but this is what she was put on: vancomycin, piperacillin, tazobactam, and ciprofloxacin. I want to cover the waterfront here. She had a very high white count. Platelets were down to 30,000, and her lactic acid was 9.3. This lady was really sick, almost died, but they did the right thing, although I would have maybe used antibiotics a little differently. Blood cultures were obtained there. She responded to treatment, probably because she was young and healthy. When cultures came back negative and consideration was given to the diagnosis of rat bite fever, she was placed on IV penicillin. Because of increased dyspnea and this unusual rash on her hands and feet, she was transferred to Vidant. Her past medical history was really fairly unremarkable, except for a penchant to raise snakes and feed them rats. When we saw her, well, when she came to Vidant, she was febrile, but she had a normal blood pressure and pulse, and actually looked pretty good. A little short of breath, and she has the right lower lobe fine rales. On her right thumb, her right index finger, and the plantar surface of both feet, she had raised erythematous lesions that were exquisitely tender, and she also had some scattered erythematous lesions on her distal lower extremities that were fairly nonspecific. They were small and raised, but nonspecific looking. And apologize for the focus, but this is the bite site, right index finger. Looked like a little pure material in the center, and very raised and erythematous. Actually, this was IMD'd, and the cultures came back. I think coag-negative staph was all that came back. And this is not the bite site, but this is her right thumb, and this is probably one of the hematogenous lesions. Also raised and exquisitely tender. Out of focus feet. She had this probably subcutaneous erythematous palpable lesion, which did blanch. It was not a ecchymosis, and this was very, very tender. She had this on both feet, and then she had some scattered lower extremity raised red papular lesions. So when she came here, her white count was 10,000. Her platelet count had come up from 30,000 to 64,000. Her lactic acid was normal. Chest X-ray showed either atelectasis or bilateral interstitial infiltrates and bilateral pleural effusions. Not that impressive, though. ID saw the patient the day after her transfer to Vidant. We felt that her chest X-ray and respiratory symptoms were due to fluid overload. She had really gotten the fluids at the other hospital when she was in septic shock. And we felt the most likely diagnosis was rat bite fever, putting everything together. We recommended that she continue to receive IV penicillin, undergo a transthoracic echo, even though the possibility of endocarditis was very low, but she did have these strange peripheral skin lesions, of course, and was febrile. The blood cultures at the outside hospital were negative when we called them, and we asked them to hold them there at that lab for 21 days. I remember that we saw the patient on a Friday, and I was saying, well, dermatology has probably not seen a case like this, maybe never. So I got up at dermatology maybe early Saturday morning before we saw the patient, and they were getting ready to see the patient. We went by and saw her, and she was so much better. Her skin lesions were really non-specific looking, so I called Derm back and said, you're not going to learn anything from this case. She's doing so well. She received 1 week of IV penicillin and then was discharged on oral amoxicillin for a week. And she and her husband were counseled about the risk of working with rats, but they were adamant about continuing to raise snakes and feed them with rats. I did say buy some very heavy gloves that the bats cannot bite through. Wash your hands very thoroughly after you work with the rats, but they wanted to keep the snakes. The outside hospital did hold the blood cultures for 21 days, and they were negative. I think this patient had rat bite fever. We can't prove it. I think the circumstances, this septic illness occurring within 2 or 3 days after the rat bite, the skin lesions, they can take a lot of different forms of rat bite fever, but they were distal, which is quite characteristic. And the fact that we didn't recover anything else from her blood cultures or from other cultures, and the fact that she had a very rapid response to penicillin. It would be nice if we had a positive blood culture, but you say for sure this is rat bite fever, but I think that's what it is. Rat bite fever is caused by two microorganisms, Streptobacillus moniliformis and Spirillum venus. Streptobacillus moniliformis is a kind we see in North America and Europe. Spirillum venus, I'm not going to talk about, really occurs in Asia. It's transmitted by the bite or other contact with rats or other rodents. Up to 2007, I couldn't find more recent data, about 200 cases have been documented in the English literature, primarily in the United States. It's estimated there are 20 to 40,000 rat bites in the U.S. annually, and I keep seeing in the literature the rate of infection after bite is 10%. That doesn't quite add up. Either we're underdiagnosing rat bite fever, or the risk after a bite is much lower than 10%. Now, since rodents have become popular pets, we're not just talking about rats here, and popular pets and study animals, those at risk include children who might have the pets, pet store owners, maybe folks who also feed their rats to snakes, and laboratory technicians. So the transmission is through the bite or scratch or even handling of rats, mice, guinea pigs, gerbils, very popular pets, ferrets. I don't know if they're still popular. They were popular a few years ago, ferrets were, or squirrels. Also for carnivores, dogs or cats who prey on rodents. The organism, a lot of studies have been done in rats, and the organism can asymptomatically colonize these animals, nasopharynx, larynx, upper tracheal, even middle ear. And here's your colonization rates, extremely high in your domesticated or laboratory rats, maybe as low as 10%, but probably up higher, 50 to 100%. And in wild rats, 50 to 100%. So this is a very common colonizer in healthy rats. Now, oral ingestion has caused epidemics of what we call Haverhill fever. I don't know if that's going to be on the internal medicine boards, if you might remember that. It could appear on your boards, which was called, and probably may still be, erythema arthriticum epidemicum. And potential sources of outbreak include foods such as turkey, milk, or water contaminated with rat excrement. I think I have time to digress here. And it's real interesting. In Haverhill, Massachusetts, in 1926, there was an epidemic of rat bite fever. 86 cases over a 2-week period. And they traced it. There was one dairy that supplied the milk to basically the whole community, and the dairy did not pasteurize the milk. Now they clearly identified the organism in most of these infected people that could never culture it from the milk or from the dairy cattle and so forth. But when they started pasteurizing the milk, the epidemic ceased. So Haverhill, Massachusetts is where we get the name Haverhill fever, which is due to the ingested Streptobacillus moniliformis. But actually, 1 year before, there was an even bigger epidemic in Chester, Pennsylvania. There are 400 cases in Chester, Pennsylvania over a fairly short period of time, again due to unpasteurized milk. The amazing thing is, this is 1925, 1926, no antibiotics, nobody died. Nobody died in this. Still don't understand that. But I'm very impressed if you go back and look at some of the old papers that looked at the epidemiologic investigation. They're quite sophisticated. I was quite impressed with, for you epidemiologists, how thoroughly and how insightful they were in tracking this epidemic down. Incubation period is short. Patients frequently have upper respiratory tract infection symptoms, followed by the abrupt onset of fever, chills, headache, vomiting, sore throat, and severe migratory arthralgias and myalgias. Usually the wound is healed by the time these systemic symptoms occur. It had not healed in our particular patient. The patient then, about 3/4, developed rashes of various characteristics, and particularly in the distal extremities. And if you've got a rat-exposed patient and has very tender hemorrhagic vesicles in the distal extremities, that's highly suggestive of rat bite fever. About 50% develop asymmetric polyarthritis or septic arthritis. Our patient had the arthralgias and myalgias but did not have frank arthritis. And I've listed the joints where that can occur. Without treatment, the fever subsides in 3 to 5 days and remainder of symptoms within a couple of weeks, but fever may relapse in some patients. The Haverhill fever, the ingestion route of acquisition of infection, in that case, pretty much a similar picture, but they have a higher rate of vomiting and more severe vomiting and a higher rate of pharyngitis. And you can have a false positive test for syphilis. Remember when you see distal lesions involving the palms and soles, you always got to consider secondary syphilis. You may have a positive RPR in these cases. And the mortality rate without treatment is as high as 13%. So I'm still amazed that 486 patients in 1925 and 26 did not get antibiotics and nobody died. Here is a rash, sort of like a pustular lesion, erythematous. That's not diagnostic of rat bite fever. But that's what you may see. Distal extremities, exquisitely tender. This is more of a non-specific kind of raised rash. This may make you think of, Rocky Mountain spotted fever or even meningococcemia. Here is a pustular lesion on the thumb. These are the types of lesions that you might see in these patients. Diagnosis can be difficult. In a febrile patient with rash and recent rat exposure, you strongly consider the diagnosis of rat bite fever. Without an exposure history, the proper diagnosis can be elusive. There was a case seen here in 1987 by anyone remember Dr. Nicholas Petrone? And Dr. Richard Rumley reported it, and they had a patient with septic arthritis, had no rat exposure, no rash, and the lab had a hard time working up the arguments. Finally, though, it was identified as Streptobacillus moniliformis, either by the state lab or by the CDC. So it can sneak up on you. But that's the only other case I know of in our area. You may see pleomorphic gram-negative bacilli on a gram stain of the purulent material or of the joint fluid. Blood cultures may be positive, but the organism is slow growing, and that's why we asked the outside lab to hold the cultures for 21 days. In that old study, in the Haverhill, Massachusetts study, they had a 65 of the blood cultures they obtained, 65% were positive, and I haven't seen that result again. It's usually something like 1 in 7 cases has a positive blood culture, so blood cultures may not help you out. And of course, the laboratory diagnosis rests on culturing Streptobacillus moniliformis because there is no serologic test or PCR that can help you otherwise. Here's a patient with keep doing that, septic arthritis of the thumb. Here's the gram stain showing these are kind of pleomorphic, kind of gram-negative bacilli, and then here they are in culture. Penicillin is a drug of choice. Tetracycline might be used in a penicillin allergic patient. It's sensitive to a number of different antibiotics. So I think a lot of rat bite fever might be treated inadvertently by just a course of whatever you use, a cephalosporin, or they're not sensitive to quinolones though, but the beta-lactams are quite active against streptobacillus. Most patients respond promptly, as our patient did. And the patient responds, you receive maybe 5 to 7 days of IV penicillin followed by a week of oral penicillin or amoxicillin. And patients with mild disease can be treated orally from the very beginning. I'm going to just, in the interest of time, I'm going to just point out here, these are, I told you there were 200 cases reported since up to 2007. This is a review including those 200 cases, but these were cases that had specific descriptive, so they narrowed the list down where they could get clinical information. And you can see of these 65 cases, 57% were from rat bites, 30% had non-bite or non-rat exposure, so this exposure to a potentially infected organism, but others had a ferret bite, a mouse bite, a squirrel bite, a gerbil bite, and even a dog bite. And here in this particular series, the mortality was almost 11%. I said in general we consider it to be about 13%. And right-back fever in Asia is caused by spirocheminus, which is a spirochete. It's even harder to diagnose because you can't grow it, and you have to see it by dark field or Giem's or Wright stain, either in a lymph node or in the blood. I'm not going to say anything more about that unless there are questions at the end. So, teaching points on this case is do not underemphasize the history. Without the history of rat exposure in this patient, the diagnosis would have been missed entirely. Now, we don't want to go looking for zebras because when their hoofbeats are usually horses, not zebras. On the other hand, we don't want to miss the rare diseases. So this is the tough part. This is the art of medicine. When is someone not behaving like they should, and you should think about a rare disease? If patients, if you don't think there's a rare disease, don't get all the tests, or don't do all the testing for the rare disease. But if you suspect it, you want to pursue that possibility. I think these three cases illustrate very well how one element of the history and physical, and especially the history, can lead you to the correct diagnosis and treatment. And I know that you all have examples of this where just one question has led you down the right path. We see this all the time in infectious diseases. And usually it's the history. And if the first two cases of tularemia, history of rabbit hunting or skinning, in the first two cases would have led us to consider more strongly the diagnosis of pulmonary tularemia. In the young woman who had the Lemierre syndrome, of course, really critical here with pharyngitis with the neck pain and tenderness. And lastly, the patient with rat bite fever would never have considered that if we didn't get a history of exposure to rats and the rat bite. I'm always impressed with how wise Sir William Osler was. And his writings kind of really encapsulated the way we think about medicine. And he was over 100 years ago, you know, when he was writing and seeing patients and was kind of the consummate physician. But I think that what he wrote in 1901 fits very, very well with these cases that we're talking about today. So he says that to study the phenomenon of disease without books is to sail an uncharted sea, while to study books without patients is not to go to sea at all. So we have to have these patients. We have to have the patients we've seen. We have to understand these patients along with books to be the kind of clinicians we want to be. So I will stop there and entertain any questions. Thank you.
Terry, I was listening to your presentation on the Lemierre's case, and I was wondering where that bacteria came from. The first thought that came to my mind when you were talking about it was dental abscess.
It can be dental. It's usually pharyngeal. It's normal flora. It's normal flora in the pharynx. The bacteria in the profit. A lot of fusobacteria are normal flora, particularly in the lymphatic crevices and so forth. And why does this one person develops a viral pharyngitis or maybe bacterial, then goes on to develop Lemierre's? I don't know, but it is part of the normal flora.
Does it mean you should look for deficiencies in leukocyte function in those people, or they just?
I'm not aware that any of those that's been shown in these patients. These are otherwise healthy folks. And I don't know if the other ID folks have anything they want to add to that about abnormal leukocyte function. I didn't run across any studies where they looked at that, but that just hasn't been suspected. These are healthy children, adolescents, adults who just happen to have the misfortune that it's colonized fusobacteria, which is very common, and it happens to invade when someone has a previous pharyngitis.
Dr. Adams, I don't really have a question, but more of a comment. I think you really showed us today the power of a grand rounds in a department of internal medicine where you bring together generations of learners and physicians. And to the residents, you can see how grand connectivity to other cases you've seen already. My own team and I were whispering back and forth. We have a couple patients we thought of on our service today. You'll also see patients in the future, and you'll remember Dr. Adams' grand rounds. So you should always make an excuse. Grand rounds is a great reason to have a duty hour violation. And thank you so much. Thank you.
I wish I had a recording of you saying this.
It's not being recorded, right?
That's true, maybe. Harry's not leaving us. I'm sure Paul told you coming in. He's moving a couple of floors downstairs, so we'll miss seeing you in the stairwell, Harry, but enjoy seeing you.
I'll be
downstairs.
working in with Dr. Baxley, Lawson, and Carroll in medical education. So working on curriculum and continue to teach. I just won't be coming over here and seeing patients, but I'll stay connected with the department and with the Division of Infectious Diseases.
Very good.
Okay, thank you.
Very nice, Harry.
Well, thank you. Thank you very much.